Hi, my name is Melanie Mara, and I'm going to talk about Dolutegravir plus two different prodrugs of Tenofovir to treat HIV. Definition: are two drugs under consideration for inclusion in antiretroviral therapy regimens for human immunodeficiency virus or HIV infection are Dolutegravir and Tenofovir alafenamide fumarate. There are limited data on their use in low and middle income countries.
After entering the cytoplasm of a CD4 cell, the uncoating of the viral core then occurs. The matrix core disintegrates, releasing the capsid with the HIV genetic material and associated enzymes into the host cell. The capsid then sheds its coat. The two viral RNA strands, which are coated, and the viral enzymes are then released into the cytoplasm. This now leads to the activation of the reverse transcriptase enzyme. The conversion of viral RNA into single-stranded DNA can now begin. The reverse transcriptase, or RT, now moves along the HIV RNA molecule and copies it into viral DNA through the incorporation of naturally occurring nucleosides. The nucleoside reverse transcriptase inhibitors, or NRTIs, compete with naturally occurring nucleosides to prevent their incorporation into viral DNA, and this in turn prevents reverse transcription. The reverse transcriptase enzyme embeds the NRTI nucleoside analog or inhibitor into the synthesized molecule of DNA. As a consequence, natural nucleosides can no longer be added to the growing viral DNA chain, which is thereby terminated. Hence, this process is called chain termination. Consequently, the completion of reverse transcription cannot take place. Hence, the HIV DNA is not fully formed and cannot be incorporated into the DNA of the host cell.
Applications in medicine. DTG has potency, resistance, and side effects benefits over EFV, and there are widespread plans to rapidly expand its use in low and middle income countries. However, association of DTG with teratogenic defects, especially neural tube defects, neuropsychiatric symptoms, and weight gain have around concern, as has the complexity of twice-daily administration with rifampicin containing tuberculosis treatment.
And now there's some recent strategies of actually maybe being able to simplify to 2 agents instead of 3. Dan made the case for 3 agents. It happened to be the right number, but it's possible in people who are suppressed, and maybe even people who are starting therapy, which we'll talk about later. But what about simplifying to 2 agents? Is that ever something we should do?
Yeah, it's possible, and particularly right now in those people who are suppressed is where we could consider switching them to a dolutegravir and rilpivirine-based regimen that was recently approved. And I found that this is to be useful in that situation I was talking about with the hospitalized patient who comes in with a new diagnosis of medical illness. It's renal failure, or it's some other, they need an anticoagulant or something like that, where I really feel like we need to drop the other medications that could be contributing to their illness.
Yeah, I would agree with you. Especially in some of our patients as they get older, and people have looked at comorbidities in HIV and counting them, and I mean some of our patients have lots of comorbidities. I know in the South, I mean diabetes, hypertension, heart disease, renal disease, and sometimes these. A two-drug therapy may be what fits for them. The Dolutegravir, rilpivirine, we do have to be careful about the rilpivirine because it does have the drug interaction with proton pump inhibitors and should be taken with food. But it's also a small pill.
No, I think you're right. It's still rilpivirine, and we have to remind everybody of that.
Right.
So all the usual caveats, but for the person taking food and avoiding acid-reducing agents, particularly PPIs, it's a viable option. And Dan talked about that conundrum we have with these people with lots of comorbid conditions, diabetes, hypertension, renal failure, where abacavir may not be the best choice based on our concerns about abacavir and cardiovascular events. And tenofovir, although TAF has opened the door a little bit for people down to a creatinine clearance of 30, people who are experiencing progressive declines in renal function, I'm not sure that if you could avoid tenofovir, that it wouldn't be a good thing to do. And now we have this, two giant fully powered studies looking that you can safely switch people to dolutegravir rilpivirine.
Yeah, I mean, Joe mentioned the magic number, and we hit on 3 drugs because we started out with 2 relatively weak drugs and added the third drug, which was very potent. And there have been attempts over the years to look at some 2-drug regimens, but now we finally really have 2-drug regimens that are highly effective, at least for maintenance. We're still exploring it for initial therapy. And I think we have to start asking, well, if 2 drugs work, then why do you need that third drug? And is there some, as yet unproven, advantage long-term to being on less drug if you don't really need that third agent, as well tolerated as it may be, to sustain virologic suppression?
I mean, that is one issue with the studies that we've had simplifying to 2 drugs. Maybe because they're shorter term, meaning 48 or 96 weeks, they really haven't shown much in the way of a toxicity advantage. Right. But it's possible over a very long period of time that advantage would come up.
And until recently, most of that's been boosted PI3TC-based regimens.
Fair point.
So no single tablets and all the baggage that comes with the boosters.
Pros and cons. The primary efficacy viral was a viral load of less than 50 copies per millimeter at the end of week 48 in the intention to treat population, which include all the patients who had received at least 1 dose of trial medication.
HealthCast, more than 1 million people in the U.S. are living with HIV, the infection that can lead to AIDS. On this World AIDS Day, our medical specialist, Christy Kruger, looks at the latest treatments and programs out there to stop the spread of HIV. Christy.
And let's start things off with the newest drug approved by the Food and Drug Administration just recently to fight HIV infection with fewer side effects. In phase 3 clinical trials, that drug called Descovy was shown to be easier on both the kidneys and the bones than its predecessor, Truvada.
It's less medication in the patient's body, and it does exactly the same thing. It goes into the cell exactly as Truvada. The only difference and the only thing that is not approved for is for pre-exposure prophylaxis.
So Dr. Eckhart is with Memorial Healthcare, and she says that means Descovy currently is not approved to prevent HIV infection like Truvada, but that could change in the very near future. And here in South Florida, one doctor is fighting HIV one dirty needle at a time. Florida is one of just 15 states that lacks a needle exchange program, despite Miami-Dade having the highest rate of HIV infection in the entire country. And as we've seen in recent months, we also have a skyrocketing rate of heroin use. But today, after years of fighting for its passage, the ID Exchange, which stands for Infectious Disease Elimination Act, has opened its doors. UM's Miller School of Medicine will run this new program, which is available for anyone who uses injected drugs.
They're going to enroll in the program, they'll get a card, they'll get an HIV test, a hepatitis C screen, and they'll get syringes. As many syringes as they bring in, they'll get. And anytime they need clean syringes, they'll be able to come in, get clean syringes. If they need referral to HIV care, referral to substance abuse, we'll be able to provide all of those services. So basically we have this huge vulnerable population in Miami that's finally going to have access to health care.
And University of Miami, Dr. Hansel Tukes, who you just saw there, spearheaded the program and says it has really reduced the spread of HIV and hepatitis significantly in other cities. That's your HealthCast today. I'm Christy Kruger.
Issue applied in Ecuador. 2 drugs under consideration for inclusion in new regimens are Dolutegravir to replace HIV and Tenofovir and laminate furamate to replace TDF, both prodrugs of Tenofovir.
There were 17 HIV infections among participants in the Tenofovir group and 33 in those assigned to placebo. This translates to a 49% reduction in the risk of HIV infection among participants taking Tenofovir, with a 95% confidence interval of 9.6 to 72.2 and a p-value of 0.01, a statistically significant result.
ผลการวิจัยนี้แสดงให้เห็นว่าหลักฐานที่แน่ชัดว่าวิธีการป้องกันการติดเชื้อก่อนการสัมผัสเชื้อมีความปลอดภัยและมีประสิทธิผลในการลดการติดเชื้อ HIV ในผู้ใช้ยาเสพติดชนิดฉีดเข้าเส้น
This is going to show us, I think, very, very importantly, the results of new prevention methods for users of drugs, injectors, and men who have sex with men. This is a study that has been carried on throughout Thailand. It's important research, and again, it's a huge step forward in our shared collaboration.
การศึกษามีวิธีการศึกษานะคะก็ต้องนะคะเรียนเชิญค่ะให้บนเวทีนะคะจะได้ถ่ายภาพร่วมกันนะคะเรียนเชิญค่ะ
And in conclusion, treatment with DTG combined with either of 2 tenofovir prodrugs like TAF or TDF show non-inferior efficacy to treatment with the standard care regimen. There was significantly more weight gain with the DTG-containing regimens, especially in combination with TAF than with the standard care regimen.
Tenofovir, presentado por Mariana Islas Gómez. ¿Qué es el tenofovir? Es un inhibidor de la transcriptasa inversa análogo de nucleócido. Se utiliza para el tratamiento contra el VIH-1, VIH-2 y el virus de la hepatitis B. Mecanismo de acción. El tenofovir es absorbido y transformado al principio activo de tenofovir, es decir, difosfato de tenofovir. Este es un provocador de la terminación de la cadena por enzimas celulares expresadas de forma constitutiva. El disfosfato de tenofovir inhibe la transcriptasa inversa de VIH-1 y la polimerasa del virus de la hepatitis B al competir con el sustrato natural desoxirribonucleótido por el sitio de unión. y se incorpora al ADN provocando la terminación de la cadena. Farmacocinética relevante. Su administración es por vía oral. No se une a proteínas y la comida grasa aumenta su absorción en un 40%. Además, se excreta de manera renal. Contraindicaciones. La única contraindicación es la hipersensibilidad a este fármaco. Reacciones adversas. En realidad, son muy pocas. Entre ellas, flatulencias es la más común, y de las más raras se encuentra el síndrome de Fanconi. Esto ha sido todo por hoy. Gracias y